Now I will talk about surgical specimen management in our university as a clinical practice. It is necessary for us to refine surgical techniques and strategies based on the pathological assessment and prognosis of the patient. Surgical specimen management is important to conduct precise and accurate pathological assessment. In this presentation, I will talk about surgical specimen management. In Japan, surgical specimen management is initiated by surgeons. I think Japanese style is unique in that surgeons contribute to surgical specimen processing. First, I show you surgical specimen processing in our university as a clinical practice. Next, I introduce pathology education program for young HBV surgeons and their clinical research in surgical pathology. After surgery, before sending specimen to the pathology department, there are various processes. And red color is processes are handled by surgeons. Immediately after surgery, surgical specimen is handled by surgeons. First, we inject 10% formalin into the liver through the hepatic artery or portal vein. After that, lymph nodes are harvested from the specimen individually and are classified into groups according to the rules of Japanese classification. The grouped nodes are put into each container of formalin. Next, the extrahepatic bile duct is opened longitudinally from the distal margin up to the proximal margin. Open extrahepatic bile duct is pinned to show ductal margin status clearly. Lastly, we take a picture of the specimen and dip it in the 10% formalin. One or 2 days after formalin fixation, the specimen is serially sectioned at 5 millimeter intervals in the axial direction. We take pictures of all serial sections and denominate video vascular structures in each slice. We especially describe the relationships between tumors and adjacent vasculature in detail. Surgical margin is also identified and indicated in the photograph for guide of pathology examination. Within 1 week after surgery, we bring specimens to the Department of Pathology. Then surgeons and pathologists discuss macroscopic findings of the specimen, and specimens are further sectioned for a microscopic evaluation, as shown in the right photo. About 2 weeks later, final pathological report is completed by pathologists. Next is Nagoya Pathology Education Program. There is an education program for surgical pathology. Junior HBP surgeons in our department have been missioned to the Department of Pathology in Nagoya University to study surgical pathology. A total of 6 junior HBP surgeons have joined this education program since 2011. In this program, young surgeons learn hepatobiliary pathology with other pathologists for 2 or 3 years. He is trained in reviewing histopathological slides and describing a pathology report for hepatobiliary malignancies as a daily practice. In addition to daily work, he also conducts clinical research about surgical pathology to get a medical degree. Junior surgeons who join the education program have published several articles on surgical pathology for cholangiocarcinoma. I will introduce some papers which affected our treatment strategy. But this, this, this slide is overlapped with Dr. Ebata's presentation. I'm sorry. Previously, several studies, including Waka et al., reported that survivors for patients with positive ductal margin with carcinoma in situ was not different from those with R0 and significantly better than those with positive with invasive carcinoma. For a long time, a positive ductal margin with CIS was treated as R0 resection in the world because R1 CIS did not affect survival. Dr. Tsukahara investigated the impact of residual carcinoma in situ R1 CIS on survival in patients with early stage cholangiocarcinoma. In this study, 172 patients with pathological TIS 1, 2, and 0 and 0 were investigated. The cumulative incidence of local recurrence in R1 CIS patients was 32% at 5 years, which was higher than R0 patients. Disease-specific survival for R1 CIS patients was significantly worse than that for R0 patients, and better than that for R1 invasive patients. This study showed residual carcinoma in situ offered worse survival in early stage cholangiocarcinoma. The prognostic effect of R1 CIS is mild and thus may be masked with other strong prognostic factors such as vascular invasion or lymph node metastasis. So when the ductal sample is positive with CIS, aggressive additional resection is considered for patients with surgically T1 or T2 N0 cancer. On the other hand, no additional resection is allowed for advanced cancer, including T3 or 4 or N1 disease. Shinohara et al. Investigated radial margin status in resected peripheral cholangiocarcinoma. Between 2001 and 2014, a total of 478 patients were included in the study. A positive radial margin was observed in 10.9% of patients. In the right figure, the dotted line in shows overall survival curve for patients with positive radial margin. The overall survival was 44%. That was significantly worse than those with R0 of 62%. The impact of positive radial margin on overall survival was similar to positive ductal margin. Furthermore, the study shows that positive radial margin on the liver transection plane was significantly high in left hepatectomy. Illustration shows liver transection line in trisectionectomy. Yellow line is a left trisectionectomy, and white dotted line is a right trisectionectomy. In trisectionectomy, liver transection plane rotated away from hepatic pylon. It results in low radial margin positivity. In right hepatectomy, showed by yellow line, transection plane can be created away from the hepatic pylon by resecting the inferior part of the segment 4. However, in left hepatectomy, liver transection plane is likely to come near the hepatic pylon because the right anterior Gleasonian pellicle must be preserved. As a result, left hepatectomy may be associated with high RM positive rate. Dr. Otsuka compared left hepatectomy with extended left hepatectomy, focusing on margin status on the liver transection plane. He showed the length of the hepatic parenchymal margin was as short as 3 millimeters in left hepatectomy, which was significantly shorter than in extended left hepatectomy of 9 millimeters. Although liver transection margin positive was not significantly defined in early stage cancer, the rate of positive margin increased in left hepatectomy for advanced tumors. Based on this study, we refined surgical strategy. We choose conventional left hepatectomy, preserving middle hepatic vein in patients with a clinical T1 or T2A cholangiocarcinoma. On the other hand, extended left hepatectomy, dissecting middle hepatic vein, is performed in patients with clinical T2B or more to reduce the risk of tumor exposure at the liver transection plane. First, Dr. Otsuka also reported benign hyla bile duct stricture resected as perihyla cholangiocarcinoma. During the study interval, 22 patients, 3.1% with benign strictures underwent resection in our cohort. The bar graph shows the number of surgery and resected benign stricture over time. The line graph shows that the incidence of resected benign stricture. The incidence of overdiagnosis did not decrease over time. The fact that the incidence of unnecessary resection did not decrease results from low sensitivity and negative predictive value of preoperative histological studies. Now, about 40% of patients have still undergone surgery without histological confirmation of cancer. In summary, surgeons who understand precise anatomy should contribute to the process of pathological assessment in HPP surgery. Detailed pathological assessment is helpful to define surgical strategy and techniques. I have a short time. Small digression, please. It's hardly necessary to say that we are from nowhere. Please let me introduce Nagoya University. You can go to Nagoya in about 6 hours on a direct flight from Bangkok. The Bangkok Airways is in service between Bangkok and Nagoya. You can easily go to Nagoya. Nagoya City is centrally located between Tokyo and Osaka, these famous cities. Nagoya is one of the 3 capital cities in Japan, with a population of about 2.3 million people. Nagoya is well known as an industrial city, and the headquarters office of Toyota, which is a famous automobile company, is located here. The most iconic attraction is Nagoya Castle. The symbol is golden shachihoko at the top of castle. I didn't know that shachihoko is an imaginary creature with a tiger head and a cat body. Nagoya University Hospital is located roughly in the center of Nagoya City. It is a Central Japan flagship hospital having 1,080 beds and 35 departments. Our HPP unit has about 50 beds. In our HPP unit, about 250 HPP major surgeries, including about 50 hepatectomy with bile duct resection for perihilar malignancy were performed in a year. In terms of the number of surgeries, surgery for pancreatic cancer is the most common procedure. Now we step up minimal invasive surgery, including laparoscopic and robotic hepatectomy or pancreatectomy. We are looking forward to your visit. We always welcome your visit for your attention.